Marty, it's looking like Dr. Ross has not been able to get logged in yet. So what I might suggest, since Kathy is logged in, that we may need to change the order of the agenda just a little bit so that we don't lose any time.
That sounds just fine. You want to give her just a few more minutes and see how she does, or do you want me to just
Kathy,
move on?
would that be okay to make a schedule change if needed?
Oh, I'm fine with that.
Okay, very good.
Okay,
So,
well,
yeah,
I'll watch and see if she comes on. Is that right?
and again, while we're waiting, let me address a few more questions that were raised this morning that we didn't have time to discuss. One of the questions is the event recorded? And the answer is yes. Second, how is your organization funded? So the North Central Texas Area Agency on Aging is a small department within the North Central Texas Council of Governments. Most of our funding within the Aging Department comes from Title III of the Older Americans Act, which is passed through the Texas Health and Human Services Commission. We also receive state funding through the Health and Human Services Commission. We're fortunate to contract with managed care organizations for relocation services. And we also receive some funds from the counties, the 14 counties in our service area. And then we have some small grants as well. We received a question, what are the requirements for transportation assistance? And for transportation that is funded by Title III of the Older Americans Act, the rider needs to be at least 60 years of age and live in one of our 14 counties. Our transportation program is very, very small. We spend about $325,000 per year on transportation, which doesn't go far for our 14 county area. So we work through local transportation providers. We ask that they give priority to folks who require medical transportation and don't qualify for Medicaid medical transportation. If anybody needs more information about our transportation services, shoot me an email and I can send you contact information for our local transportation subrecipients. Question, how long does your agency provide home delivered meals? We work through our nutrition providers, usually county committees on aging or Meals on Wheels programs. Those home delivered meal services are a bit of a departure for us. As Kathy mentioned this morning, most of what we do is short-term in nature, but with the meal program, some clients receive services for years and years and years. So they do have to qualify on the basis of functional impairment. Some people will be brought off the meal program as their condition improves. But again, that service is a bit of an anomaly in that clients can receive ongoing assistance. How long does your agency provide emergency response services? Usually for 3 months only, while that care coordination or caregiver support coordination case is open. Can we receive a copy of the service limits? Yes. I believe those are included in the PowerPoint presentation, and if you need more detail, feel free to reach out to either Kathy Stump or me. And fantastic, it looks like all of our presenters are on, which is fantastic. So we'll give the rest of our participants just a couple more minutes to log on, and we'll get started here very shortly. So I am in the office working today, and the mowers the lawn maintenance folks are also working today. So I hope you all appreciate our freshly manicured lawns. And while we're waiting to get started, if you all do have additional medical questions, please feel free to submit those via chat. And a quick reminder regarding continuing education units, we will be awarding CEUs for social workers, licensed professional counselors at the end of the day. Folks would need to participate in both morning and afternoon in order to receive the CEUs. So after this afternoon session is open, please complete the online evaluation and then send an email to Marty certifying that you have participated in the entire program and completed the online evaluation. So apparently he did receive a lot of emails this morning. I'm done. No, not quite. And Marty, are you okay with us starting?
I'm ready when you are.
Okay, fantastic. Dr. Ross, are you okay and getting started as well?
Yes, I'm here. I'm ready.
Fantastic. Well, thank you all for joining us again. We do want to stick to our agenda as best we can. We've got a lot of information to cover. So this afternoon, we're going to be talking about medical considerations. We'll talk about Medicaid benefits for nursing home residents. We'll talk about state-funded in-home services through the Health and Human Services Commission. And then we'll also be discussing ways in which family members may be compensated as caregivers. And then we will end the day with a conversation regarding the Family Medical Leave Act. So let me introduce our first speaker of the afternoon. I am delighted that Dr. Sarah Ross is with us. Dr. Ross is Assistant Professor of Geriatrics at UNT's Health Science Center, and she is board certified in family medicine, geriatrics, and palliative care. She feels that her job as a physician is not to make all of the decisions for her patients, but educate them on their choices, risks, and benefits of various treatment options. Fluent in both English and Spanish, Dr. Ross enjoys taking care of Spanish-speaking patients. And in addition to caring for patients, Dr. Ross trains medical students, helping them learn how to interact with older adults and support their family caregivers. Dr. Ross is a member of the American Geriatric Society, American Academy of Hospice and Palliative Care, and American Medical Directors Association. So, Dr. Ross, I would like to ask a few questions that were posed either before the webinar or during this morning's session. And the first question I'd like to ask you, is it true that warmer weather will prevent the spread of COVID-19?
I think that's a very interesting question, and it's hard to give a straightforward answer to that because this is a new virus that we do not have all the facts on. So based on kind of comparing the current COVID-19 virus to the flu virus and other types of coronaviruses, there is some reason to believe that the spread of the disease may decrease with the warmer weather. But unfortunately, I think that benefit of the warmer weather is probably negligible based on how quickly and easily this current coronavirus COVID-19 spreads.
Mm-hmm. So again, just a lot of unanswered questions. So Dr. Ross, I received a question that is fairly detailed. I think it's a great question. I'm not sure if it's truly medical in nature, but let me just present the scenario and see if you have any thoughts. So a nursing facility told a family that their mom must have a negative test before she could be admitted to a memory care facility. The hospital said she didn't qualify for a test and they wouldn't do it. So the facility refused admission, keeping the deposit. Can asymptomatic patients get the required tests before admission to or discharge from a care facility?
So I think this is, as you kind of alluded, not just a medical question. It's really a public health question, procedural administrative question. And I think as things evolve, some of these answers will hopefully be more evident. I guess to address first the testing of asymptomatic patients as a general rule is not happening due to limited resources with regards to testing. So the tests are that we have for COVID-19 are being reserved for those with whom it's going to make a difference in their treatment, healthcare providers as well, those in higher risk populations. And so if from a public health standpoint, it's determined that those tests are needed prior to transferring patients to certain locations, then perhaps that will be happening in the future. But it's a very complex problem because there's a lot of things to consider when discharging a patient from the hospital, whether they are or are not positive for COVID-19, and does the accepting facility have the staffing, the supplies, the infection control capabilities, and the physical structure, to care for somebody adequately. In particular, when we're talking about an infectious patient, is there, the capability in place to properly isolate and provide infection control. So again, I don't think I provided an answer to that question, but those are some thoughts regarding that situation.
Sure. But again, limited resources in terms of testing ability at this point. So asymptomatic folks in general will have difficulty being tested.
Correct. And kind of the bigger issue with regards to, as there's more cases of COVID-19 in the community at large, then these hard questions about facilities accepting or not accepting patients are going to need to be addressed.
Okay. Next question, are you all seeing new patients? We're hearing that it's sometimes difficult to find new doctors to follow residents who've discharged to the community since many doctors have switched to telehealth. And I understand that that's great technology, but doesn't always work well for annual physicals or assessments. I know I've reached out to some home call programs and have found that they're not accepting new patients. So how are you handling that? And what do you hear from your colleagues in the community about accepting new patients?
That's a good question. I think the short answer for our practice is yes, that we're trying to accommodate folks that are new patients that need, to be assessed, to be given refills, etc. My impression is that, many practices in the community are are kind of on pause, doing telehealth for established patients, but not opening up appointment slots for new patients. Those that are seeing patients in the office tend to have, an extensive screening procedure before bringing those patients in, and they're coming in for acute needs only. And some of the hospitals or some of the clinics that are connected to hospital systems, their procedures are kind of being dictated by those bigger hospital systems in some cases. At our geriatric practice at UNT Health Science Center, what we decided to do when this pandemic hit was basically take the list of patients that were scheduled in the next few months as new patients coming into our clinic, and we transitioned them to house call visits when available and possible. So, we recognized that some of those folks on our schedule for May might have moved from out of town, might, not have a doctor in town. And so that was the plan that we put into place to accommodate the needs of patients that were already on our schedule as new patients coming up. And, just kind of to be seen. I think that we have to all be very flexible. So as far as accepting additional new patients, I think we're open to it, taking into account obviously precautions for patients and for providers. But it's tricky because, we have a lot of precautions and a lot of considerations we have to take into account.
Fantastic. So can you tell us just a little bit about your clinic for the benefit of those who may live or work in the greater Fort Worth area?
Sure. We have an outpatient office on 855 Montgomery. That's the Geriatric Assessment and Planning Program. And we have 5 geriatricians and 4 nurse practitioners. And all of the providers in our group do a combination of outpatient office visits for older adults, long-term care settings such as assisted livings or nursing homes. And then we also have a house call program that's been going on prior to this situation. So at the present, we're, seeing some folks in house call visits that aren't normally part of that house call program, but obviously under the circumstances, that's the best way to see somebody face to face for meeting their medical needs. So typically our house call program is only the homebound, and again, we kind of go to all those settings of care where we find our older adults.
Okay, is that Tarrant County only for the house calls?
That's an excellent question. We started with a 15-mile radius outside of our clinic location, and kind of beyond that is case by case. So to just kind of be brief, that's case by case beyond 15 miles of our clinic building.
Okay, so we had a question that came in about dealing with the effects of isolation, and it sounds like the question is specific to a loved one who is currently in a facility, but I think the same concerns would emerge if somebody has returned to the community and is in some type of quarantine. So the question is, how can facilities and families counteract the effects of isolation?
I think it's a question that is applicable to everyone, because I think everyone, under the circumstances in some form of a different situation and being more isolated than they previously had been. And some of the things that are important would be routine and predictability. So when there are things outside of our control, we want to have things that are predictable and help us to feel safe and help us to know what the next thing is on the schedule. So whether that is, caring for a loved one at home or being part of a, community in a facility setting, having a routine is something that really helps our brains to not feel so much of the chaos that's going on around us. And, you know, the technology is such that, you know, we're in a better position to avoid some of the negative effects of the isolation than they were, you know, in the 1918 pandemic, for example. We have our webinars, cell phones, FaceTime, etc. And so, you know, trying to just connect with people, whether it's a phone call or a FaceTime or playing a game over the phone or over some kind of technology. I know some of that can be challenging for, in particular, residents that might have dementia that are in a care setting, or older adults that can't participate in some of that. But from what I've seen in the facilities I go to, the caregivers in that facility are trying to assist with providing opportunities for FaceTime, etc. The other two things I would mention is music and games. So just something funny, fun, levity, something that makes you laugh, and music. Those are very powerful things that can really help our moods when we're in really tough situations as well.
Excellent. So we had a question about what symptoms family members should look for, and Dr. Knabel had talked with us this morning about fever not always being a surefire indicator of whether somebody has COVID. So can you talk a little bit about symptoms that family members should look for, and do symptoms present differently among older adults?
Sure. I think to follow up or circle back about the temperature question, it definitely can be accurate that older adults might not mount as high of a response with regards to having a fever present. So what might be a little more helpful is having knowing the baseline temperature. If temperatures are being checked on a routine basis, then you know what that older adult's baseline temperature is and what might be elevated for them. The main things with, I know that there's been a lot of attention to some of the rare symptoms that show up with COVID-19, but the most common are the respiratory. So all of the coronaviruses attack the respiratory system, and the COVID-19 is no exception to that. So cough and shortness of breath are really the main symptoms that we would anticipate to be the most common, whether that be for younger adults or older adults. There's, again, a list of multiple other symptoms that can be possible, but that family of viruses is known for attacking the respiratory system. So that's really the area that we'd expect to see symptoms first.
Super. And then I think this is probably the last question that we'll have time for this afternoon. Dr. Ross, do you know what facilities are doing to encourage social distancing between residents? And the person who posed the question said that would likely be difficult for those who are ambulatory and may not understand.
Yes, some of the things that I've seen or heard of is doing activities at the doorways of rooms, and so residents stationed at the doorway of their room, halfway into the hallway, to play bingo or to do some chair exercises, so that some of those activities that they're accustomed to having on the schedule can still happen, but with that social distance in mind. Definitely memory care communities are a more challenging group, because you have wanderers, you have folks who want and need to just be on the move and don't have a capability of understanding what what the risk might be with regards to having close contact and whatnot. I don't have a good answer for that. I saw something on a different webinar about making wearing masks something that's fun, or incorporating jewelry or dress up into wearing a mask as a potential way to help those folks to be a little bit more, have a little bit more precautions in place. But I think that there's not a right or wrong answer for those memory care units and patients, because you really can't, you know, restrict them to their room or to being 6 feet away. So that's a challenging environment.
Yeah, and one of our participants noted that he does visit facilities and he's seeing several that are not allowing residents to leave their rooms, that they've canceled meals, games, and other activities. So I can certainly see where that would just fuel that sense of isolation.
Yeah, and I have seen that as well. And so kind of doing the hallway things would be a compromise, I guess. But yeah, a lot of folks, a lot of facilities have been very strict about following those guidelines, which yeah, it does raise the risk of that isolation being more of an issue.
Okay, and I said that was the last question, but let me pose one more that I think is going to bleed over into our next presentation. And the question was, how is the transition or relocation process different for people in assisted living or residential care homes? So are there any medical considerations that are different? I think there are some benefit issues that are different. But Dr. Ross, anything medically?
No, I think whether you have an individual who's moving from a skilled nursing facility to a house in the community, or an assisted living or memory care assisted living community to a private home, the considerations would be the same. Does the support system at home have the capability of caring for that individual? Who will their doctor be once they are in the community? Will they have adequate supply of medication? Will they have the medical equipment that they need? So it's the same list, I think, to go down and make sure that their care can be achieved in the community setting.
Fantastic. Well, thank you for that information. That was really valuable, and the time just flew. So, Dr. Ross, thank you so much for your participation.
You're very welcome. Thanks.
The next topic we'll discuss is the relocation process for residents with Medicaid. And I'm going to move through some slides pretty quickly. And I'm delighted that joining me during this session are Michelle Rodriguez Samaron with Cigna and Karen Zisk with Molina. I have received a number of questions about the relocation process, whether that's continuing. So I do want to carve out just at least a couple of minutes at the end of my slides to discuss that issue. But Marty, we'll go ahead and so one of the intricacies of Medicaid that may be lost on some family members is, you know, there are several ways to receive Medicaid benefits. One is to have very, very low income, less than $783 a month for a single person, and receive a supplemental security income or SSI check. And those folks receive full Medicaid benefits in addition to that monthly check. The other pathway to Medicaid is through qualifying medically for institutional care and nursing home care in particular. And so that's how probably the majority of nursing home residents who receive Medicaid benefits qualify, and they receive medical assistance only. They don't receive that monthly SSI check, but they do receive Medicaid assistance with their medical care. And again, that's tied to meeting medical necessity for nursing home care. So if you're working with a family member, working with a consumer, and you're not sure which type of Medicaid she has, couple of options. We recommend checking with the business office, and I think checking with the health plan or the managed care organization is often a good way of figuring out what type of benefits. This distinction is pretty important when we talk about the relocation process, because the risks are different for those folks who receive full Medicaid benefits as opposed to those who receive medical assistance only. So we'll circle back to this issue in just a couple minutes. So the way that Medicaid benefits are delivered in Texas, the Health and Human Services Commission is the Texas Medicaid agency, and it contracts with health plans or managed care organizations, known as MCOs, to manage Medicaid benefits for adults through a program called STAR Plus. And currently, there are 5 health plans under contract with the Health and Human Services Commission for STAR Plus services, and those 5 health plans are Amerigroup, Cigna, Molina, Superior, and United. And again, it's a privilege to have both Cigna and Molina on the line with us today. So there are 2 types of STAR Plus benefits. So those adults who receive full Medicaid benefits, again, because they've been approved for supplemental security income, they receive STAR Plus benefits. STAR Plus waiver benefits are much more comprehensive, but it's also more difficult to qualify for waiver benefits. So in order to receive waiver benefits, an adult would have to receive full Medicaid benefits or medical assistance only benefits and qualify medically for nursing home care. So again, eligibility for the waiver is going to be tied to medical necessity for nursing home care. So I've seen data suggesting that about 2/3 of nursing home residents are funded by the Medicaid program. Most of those residents would meet the eligibility criteria for STAR Plus, but some people who are in the facility short-term for rehab wouldn't necessarily qualify medically for nursing home care. And also there are some residents whose care needs are so complex that they wouldn't qualify for STAR Plus waiver because the waiver benefits wouldn't be sufficient to meet their needs. So in most cases they would qualify, but not all cases. So I'd like to just touch very quickly on the benefits that are available through the STAR Plus program, and then turn to the benefits available through STAR Plus waiver. So the benefits that are available through the STAR Plus program are primary home care, which would be assistance with personal care, that attendant care, day activity health services, and community first choice, which is a bundle of services that can include emergency response devices, attendant care, and so on. The waiver benefits, as I mentioned, are much more comprehensive, and benefits that may be available to waiver participants include adult daycare or adult day activity, assisted living. The STAR Plus program can pay for assisted living for Medicaid beneficiaries who qualify medically for nursing home care. The waiver can pay for home delivered meals, adaptive aids, minor home modifications that are necessary for health or safety, so wheelchair ramps and grab bars. The waiver program can pay for personal care. Marty, if you go to the next slide. It can also pay for emergency response devices, respite care. Please note that this is not an exhaustive list of benefits, and all benefits must be authorized by the health plan on the basis of members' needs and eligibility. So I think of waiver as really being the Cadillac of social service programs. So we talked about the Health and Human Services Commission contracting with health plans to manage STAR Plus benefits. Under those contracts, the health plans have responsibilities for assessing members' needs. They have responsibilities to put into place acute care services for members who have Medicaid only, using their network providers, and their members who have both Medicare and Medicaid can receive acute care from any Medicare provider. They're not necessarily limited to that network of providers under contract with the health plan. The health plans will also arrange long-term services and supports for their members, depending on members' individual needs and their approved care plans. So during the normal times, if there are any normal times, and here I'm referring to pre-COVID times, the way the process works is the resident or the family member or other advocate would tell the health plan service coordinator that he wants to go home. The health plan service coordinator would do a face-to-face assessment, generally within 2 weeks. The service coordinator would develop a plan of care, would arrange services, and the timeline can really vary. But in general, the process usually takes at least 45 days or so. Now, if the member also needs housing, that can really slow down the process. But we're just talking about the health plan's responsibilities. So again, during normal times, the service coordinator would make a referral to the relocation specialist, and the relocation specialist would help arrange non-Medicaid services. So that relocation specialist would help look for housing, set up a bank account, make sure that Social Security benefits are transferred from the nursing facility to the community residents. Would set the person up with public transportation as needed, would buy and deliver transitional grant items as may be approved by the health plan. And again, that process can vary, but generally that takes at least 45 days. If somebody's looking for a subsidized apartment, we're generally looking at a year or longer. So unfortunately, it is rarely a quick or easy process. So during normal times, a resident must be approved for STAR Plus waiver before leaving the facility to avoid, at best, a disruption in care, at worst, potential loss of benefits. And as I mentioned a couple minutes ago, the risks are a little bit different for those who receive full Medicaid benefits as opposed to those who receive medical assistance only. So during normal times, residents who receive full Medicaid benefits, again, those are the residents with the very lowest incomes, in general, no more than $783 a month for a single person. They can leave the facility before STAR Plus waiver services are authorized, and they won't lose their Medicaid benefits in doing that. However, that does create a delay in setting up any waiver services. So the way the process works prior to COVID is the member would reach out to the service coordinator and request an upgrade. And that can be done when the member is in the community, and then the health plan would do an assessment, see if the member qualifies for waiver services, and then would set those up as indicated. So again, under normal times, somebody who receives full Medicaid can leave the facility before the waiver is authorized and still retain her Medicaid benefits. However, that resident would waive eligibility for the transition grants. During normal times, the risk is much, much greater for those residents who have medical assistance only. Those are the folks with higher incomes, up to a little over $2,000 a month, and who are qualifying for Medicaid only because they qualify medically for nursing home care. So the normal process is, if somebody receives medical assistance only and leaves a nursing facility before waiver benefits are authorized, that person loses waiver benefits, loses Medicaid. That person can be placed on the STAR Plus interest list, but currently there's about a year wait for STAR Plus waiver services. So COVID has really changed things in a lot of ways. Some of the ways it's changed things, Marty, if you can go back to the prior slide. So service coordinators can't go into nursing facilities, like the ombudsman, like the regulatory folks. They've been asked to stay out of the facilities. The service coordinators can perform limited assessments over the phone, but they can't fully complete the paperwork necessary to get STAR Plus waiver services set up. They can provide telephonic services, but those may not be sufficient to perform all essential tasks. For example, one of their responsibilities when relocating a member to the community is to make sure that the new living arrangement will meet the member's needs. Currently they're not able to do that. So they're severely constrained in a lot of ways, and I think have been working hard to develop workarounds, but the problem has been there are policies at the state and federal level that don't allow much flexibility, and so they are waiting for clarification from the Health and Human Services Commission, as well as the Centers for Medicare and Medicaid Services. Marty, if you can go to the next slide. So there are some COVID-19 related service disruptions. Some assisted living facilities are not admitting new residents. Many adult day activity centers have closed. Some doctors are not doing face-to-face visits, as we discussed with Dr. Ross. Some home health agencies may have difficulty staffing. We haven't heard of many difficulties yet. Attendant services may be delayed. So one of the really critical risks to consider if somebody is relocating is to the extent possible to be approved for waiver services before they leave the facility. If that's not possible, again, at best, there's going to be a gap in service, and worst case scenario, that person would potentially lose all Medicaid benefits if they had medical assistance only, as opposed to full Medicaid benefits. So recommendations would be to contact the health plan service coordinator as soon as possible to find out if services will be available and how quickly they can be arranged. Second, notify the nursing home social worker, who usually works to set up Medicare home health services, medical equipment, in some cases supplies for those who qualify. The facilities do have responsibilities for discharge planning, but again, they can't participate in the discharge planning process if they're not aware that a resident is contemplating relocating. The last slide I wanted to share with you includes the points of contact for all of the health plans. And in just the few minutes, looks like 3 minutes, I did want to raise a question to my health plan colleagues, Michelle and Karen. And the question is, will the relocation process continue? And Karen, it looks like you're muted.
Yeah, I just unmuted myself. Thank you, Donnie. So at this point, we are considering relocations on a case-by-case basis. So again, I think you've raised some really good questions about risk and just making sure that people have access to the services they need once they enter the community is really critical. And helping a person to think through that process. So that really is going to affect whether we can assist a person to relocate or not, is ensuring that health and safety out in the community.
Mm-hmm.
And right now there may be a delay in services. And again, we always want to make sure that people understand what the circumstances are around the ability to provide services. So if there were a delay, of course, we would make the individual aware of that or the family aware of that so that people can make informed decisions. Some people have lots of support out in the community. Some people have just a little and some people don't have any, and all of that affects whether somebody returns to the community.
Mhm.
And we've also had some challenges with medical providers, as has been mentioned several times. This is being closed, or they're limiting visits. So when a person leaves a nursing facility, they leave that 24-hour care and access to, a medical director for, if they get sick or they need prescriptions. And so, when somebody leaves, they have to have that medical provider in the community to be able to do that. So all of that affects relocations, but having said that, we're not, we would try to relocate anybody that chooses to relocate, but with the understanding that there may be, things may not happen as quickly as they like, and that there are risks, and understanding what those risks are, and trying to mitigate those as best we can.
Okay. And Karen, we had one more question from a participant who has working knowledge of the relocation program. And her question was, will the member be eligible for transition assistance services and supplemental transition supports grants?
Well, so they are. That's part of the STAR Plus waiver benefits. But whether there can be a delay in providing those benefits is a question that HHSC will need to answer. But those are current benefits for relocation. And just to clarify, some of the challenges that we ran into after COVID was, of course, stores being short on supplies. And so those are some of the benefits that we're able to, put in place for people that are relocating, food and, household items. And so, again, if those aren't available to a person and they need them, that may influence a person's ability to relocate out into the community.
Sure. Okay, that's very helpful.
Yeah.
So again, we're just really focusing on the communication with the service coordinator, waiting on policy direction to see if greater flexibility can be provided. Desire is to support the members' wishes to the extent possible within the policy constraints. Okay, very good. Michelle, is there anything that you would want to add? Okay, super. Thank you so much, Karen. All righty, we will move to our next session, and that is taking a look at in-home programs through the Texas Health and Human Services Commission. And Kathy Stump is going to lead us in that conversation again for the second of her 3 presentations. So Kathy, take it away.
All right, you guys must not be tired of hearing from me, because here I am again. All right, so we're going to be talking about Health and Human Services Community Care Programs. So this is formally known as DADS. It is the Department of Aging and Disability Services. If you call their 888 number, it still says, "Thank you for calling the Department of Aging and Disability Services." So there's a little bit of a lag time between what they're actually calling themselves and what their former name is. So they're kind of like Prince. They change their names a couple of times, but we are going to be talking about them in the sense that they are HHS, knowing that a lot of people still know them as DADS. So we're talking strictly about state-funded services, not the waiver programs. So we're talking about them administering Medicaid and state-funded programs, including long-term care programs for people in the community. These programs are means tested and limited to Texans with low incomes and limited resources. So I listed all of the programs here that HHS has. So just a quick overview of them. Community Attendant Services provides non-skilled, non-technical in-home attendant care services that provides assistance with activities of daily living, bathing, dressing, grooming, toileting, meal preparation, light housekeeping. Adult foster care is for individuals who need residential care, providing assistance with personal care. It's kind of like an alternative to assisted living, but for those individuals who do need a little bit more hands-on care. Consumer managed personal attendant services. SIMPASS is a personal assistance service program for individuals who can supervise their own attendants or delegate supervision. It does provide that attendant care or assistance with activities of daily living. All right, day activity health services. So you've seen in some of the other slides that Donnie had presented with STAR Plus and STAR Plus waiver that day activity health services, they benefit under those programs. Well, the state actually has it as just its own separate program. So this is for individuals that do need to go to adult daycare. Deaf, blind, multiple disabilities. I threw this one in there. It's not one we see a lot, but it is a waiver program that's designed for individuals diagnosed with deaf blindness or a condition that leads to deaf blindness. The emergency response service, again, we've seen that term a lot. It's that life alert system, help, I've fallen, I can't get up. So the state does have a program that pays just for that emergency response system. Family care services, this is very similar to community attendant services and primary home care, which we heard on those STAR Plus slides. It provides that non-skilled, non-technical attendant care services that provides assistance in the home with activities of daily living and light housekeeping. There's also the home delivered meals program or the Meals on Wheels, which the state can fund. So it doesn't have the same requirements that like the Area Agency on Aging does, which we talked about this morning. And there's residential care. So this is an alternative to assisted living. It's for individuals who do not require daily nursing intervention, but it does provide a place for them to live. So for these non-Medicaid services, there is limited state funding available for most of these programs. There's waiting lists for all of them. I don't believe there's any of those state-funded services that are listed. The day activity health services, emergency response service, family care, home delivered meals, residential care, and SIMPASS. They all have waiting lists. The times are variable. The state did provide us with a little bit of information that they are requesting additional funding for these services so that they can, try to get more people off of them. But some of the interest lists are, 3 years long, some of them are 2, some of them are, a couple of months. It really depends on the funding. So the income limitations for these programs are the exact same as they are going to be for the long-term care Medicaid programs. So it's less than $23.49 for per month for an individual and less than $4,698 for a couple. The difference is going to be these resource limits. It's the resource limit on these non-Medicaid programs is $5,000 for an individual and $6,000 for a couple. So the Medicaid program, or the program that's funded by Medicaid, is Community Attendant Services. It is not on a waiting list because it's not a full Medicaid program. It only pays for that attendant care. So they do not get all those benefits of Medicaid. They cannot get doctor's visits. They don't get Medicaid transportation. They're not enrolled in a managed care. The only benefit they're getting is that Community Attendant Services. So with the Medicaid income limits, you can see it's the exact same as what we just talked about, that $23.49 for an individual, but you can see the resource limit has dramatically decreased. So the resource limit on all of these long-term Medicaid programs is less than $2,000 for an individual and less than $3,000 for a couple. So how can you access these services? So this is the regional contact number for Health and Human Services community care programs. You can call and request to be placed on every waiting list they have available. You can call this to request getting on STAR Plus waiver interest list. You can call this to request to get onto community attendant services as well. All right. So those are the state-funded services. And then, of course, community attendant services is Medicaid funded, but it's not a full Medicaid program, so it's not on a waiting list. I did ask the state about their COVID-19 processes, and so all of their visits are currently being conducted over the phone. So there is a slightly quicker time frames for them to contact the clients. However, because Medicaid is so overrun, you're probably looking at a longer time frame for getting approved for Medicaid. We used to say 45 to 60 days. There's no time frame given currently for that. All right, so we are going to jump straight into getting paid as a caregiver because this coincides directly with a lot of the services that we just talked about. So we get this question at the Area Agency on Aging probably 10, 12 times a day. How can I get paid to take care of my loved one? Or I need to get paid because I need to stay home and take care of them. So in Texas, there are no programs with the sole purpose of paying family caregivers. All the programs are set up to meet the needs of the care recipient or the person who is needing care. Some programs do allow the family members to be paid under certain circumstances. If you're interested in being paid to be the caregiver, you first have to get your family member approved for a program that provides those services. So the programs that allow family members to be paid under certain circumstances, these are the two programs that do provide that in-home attendant care services, is that community attendant services and Star Plus, and within that Star Plus waiver as well. So those are the ones that provide that attendant care. So community attendant services, again, there's no waiting list. It used to take 45 to 60 days for Medicaid approval, but due to the COVID-19 issues, it's currently taking longer. And again, there was no timeframes given at the time I requested the information.
Actually, Kathy, we have a participant with HHSC who writes the current time frame in Region 3, which is the greater DFW area, is about 90 days. So thank you for that.
Yeah, well, when I spoke with Karen Brock, she said that they weren't giving out timeframes just because with the Medicaid issues, they weren't sure. So 90 days is a good thing to know. So around 3 months or so for that to go. And obviously that could vary depending on the issues going on with COVID. So, all right, with Star Plus waiver, there is that waiting list of up to a year. Once you come off that waiting list, it usually can take up to 4 months to get approved for services due to you have to go through the Medicaid process and the medical necessity process, and of course waiting for everything to get into place if you are going through the community option, not the nursing facility relocation. So again, for those Medicaid programs that pay for services in the home, they have to meet those Medicaid income and resource limits. So again, that $23.49 for an individual, resource limit of $2,000. They have to have a need for assistance with personal tasks. So that's those assistance with activities of daily living, bathing, dressing, grooming, toileting, and meal preparation. They have to have an unmet need for the service. So if all their needs are being met, what's the purpose of them applying for the program? So that's what you kind of have to consider when you are applying for these services or asking these questions, is if this person's needs are being met and they don't have a need for this, then you may or may not want to apply. Again, for Star Plus waiver, you also have to meet that medical necessity for nursing home care. All right, so a couple of things to consider if you're wanting to be paid to take care of your loved one is the pay rate for attendance. It's determined by the Medicaid reimbursement amount. Most agencies pay around minimum wage. Some pay slightly above, but you're not going to be making, $50,000, $60,000 a year being an attendant because unfortunately these rates of pay are very low. The amount of hours is based on the needs of the individual. So the programs are not going to provide you with 40 hours a week because they're not an employment agency. That's not their purpose. Their purpose is to provide that assistance and care for the needs of the individual who is in need of those services. So the program that's providing the service is going to complete the assessment to determine what the individual's needs are. Based on those needs, they'll determine the amount of time that the person is going to get. So generally it's a minimum of 6 hours and you know, whatever the maximum might be. And most programs do not provide full-time care because again, it's going to be the needs of the individual, not based on employment needs. In these programs, spouses cannot be paid to be the caregiver. So we do get that a lot, you know, I'm taking care of my husband and I need to supplement my income, I need to get paid. That's not a purpose of those programs. So another program that individuals can get paid under to take care of their loved ones is through the VA. Those veterans and their dependents may be eligible for community-based home care services, such as aid and attendants. So there is definitely different qualifications than Medicaid. So those are, if you want to skip to the next one, there you go, Marty. The Aid and Attendance Program serves veterans and surviving spouses who require regular help with those activities of daily living. It does take income and resources into consideration, and unfortunately, I don't have those income and resource limits, and that's not something they publicize, so it's not something I had on hand. The veteran and or the dependent can choose who provides that service if qualified for that program. So how do you apply for VA services? Well, there's a couple different ways. You can apply, contact the Veterans Administration. You can call the Texas Veterans Commission hotline, or you can contact the County Veterans Service Officer. Every county has a Veterans Service Officer that is not paid by the VA, they're actually paid by the county. And they act as advocates for individuals who are needing assistance with applying for benefits, doing pensions, applying for aid and attendance, anything that you might need assistance with. So that's generally what I tell people to do, is to contact that Veterans Service Officer because they're gonna help them navigate that process.
And Kathy, I do have some information on the 2020 income and net worth limits. So it's different depending on whether it's a single veteran, a surviving spouse, a married veteran. But for a single veteran, the income would need to be below $1,911 a month. A surviving spouse would need to be below $1,230 a month. And the net worth for the claimant and their spouse can be no greater than $129,094.
All right, well, thank you for that information. All right, so some of the risks for being or applying to be the paid attendant is if you are the paid attendant, you don't qualify for respite services. So if you're on community attendant services, or if your loved one's on community attendant services and you need a break and you contact the area agency on aging, we're not going to be able to provide respite services to you because you're the paid attendant and that person's already getting services. You are at risk of caregiver burnout because being a caregiver is very hard. You know, most of the time it's a 24-hour job, and if you're getting paid to do it, but then you're getting paid for however long during the day, but then you're also doing it all night, and then all that time you're not being paid, you do have a higher risk of caregiver burnout. Again, these programs are not designed to provide, you know, 40 hours a week. So you may not be getting enough hours. If your loved one only qualifies for 8 hours a week, that's all they're gonna get, and that's all you're gonna get paid for. We discussed that low rate of pay. Again, Medicaid funded services, that Medicaid rate of pay is determined by the state and by the Medicaid requirements. So again, it's generally minimum wage or slightly above. not everyone's going to qualify for services. So even if your loved one needs assistance, if they are over resources for these programs, they cannot get on these programs. Or if they're over income, you know, or if they don't meet the medical necessity for Star Plus waiver, if they don't, whatever the case is, they may not qualify for services. And then not everyone's going to qualify to be the paid attendant. The case manager or the service coordinator does have to approve those individuals. And if you're currently doing that task and then you go and you know, your loved one says, well, you know, my daughter helps me with that, you may not be able to be paid to help that individual with that task once the assessment's completed and the person's on that program. All right, so how do you get started? So again, you contact your Health and Human Services community care programs. That 888 number is the regional, so that covers the entire 16 counties in this area. If you're out of this area, there are different numbers for those. You can, of course, contact me and I can certainly look it up for you, or shoot me an email. And it's important to know, if you call that intake line and you say you want to be paid, you're going to be told that there's no program that does that, because that's true. There is no program that does provide employment opportunities. You will want to state that your loved one is in need of services. Once the individual goes through the process and gets on to those services, then you can apply to be the paid attendant at that time. All right, so I wanted to give everyone some resources for caregivers, because again, being a caregiver is hard, not only, you know, financially, but emotionally. So there's lots of resources out there for individuals. Again, you can contact the Aging and Disability Resource Center, statewide resource line. It gives you tons of information. They're really great. You can call the area agencies on aging. I've listed the ones in this area. Alzheimer's Association for individuals who have Alzheimer's and or dementia. A lot of people don't realize that it's not just Alzheimer's, it's dementia and those related disorders that Alzheimer's can give you information, resources, education, training on. And then we do also have the Family Caregivers Online. It's familycaregiversonline.net. Tons of information, training, education, resources for caregivers and individuals who just want to learn about being a caregiver.
So Kathy, that was great information. I've gotten a lot of questions, so I'm going to see how many of these we might be able to address before we move into our final presentation of the day.
Okay.
And this one, let's see. Can you please repeat the 2 programs with no waiting list?
For attendant care services, the only program that doesn't have a waiting list is community attendant services. So there is no waiting list for that. All the other programs do have waiting lists.
Okay. Is it a guarantee that if somebody is on community attendant services or has Star Plus waiver, that the individual can have a family member become a provider?
No, there is no guarantees on anything, because again, there's a lot of different variables that go into play with that. One of them is background checks too. If the person's currently doing it, they may or may not get paid for that. So there's a lot of different variables. So there's no guarantee that someone is going to be able to be the paid attendant.
Okay. This is a question that we might want to ask for either Karen or Michelle to help with, but Kathy, let me run it by you first. I know there was a change where family members can now be caretakers for Medicaid individuals. Are parents excluded still?
Yeah, I don't know that one.
Karen or Michelle, do you know if parents are eligible as paid providers?
So, hi, Ms. Johnny. This is Michelle. Can you hear me?
Yes.
Okay. So, it may be a 2-part question. So, parents were excluded from being the providers for children, I believe, that were in the HCS benefit, as well as the spouse. For provider attendance or the pause, the parents were not excluded, but again, it goes back to the presenter's comment that she made. It's not guaranteed that they may actually receive time for the tasks that they're doing.
Mm-hmm. Okay. And Michelle, you might be able to help in responding to this next question. I would throw it open to the group. Is there a document identifying what qualifies in Texas as medical necessity for nursing home care? Many nursing homes only use dementia as a qualifier.
I can kind of answer that if you
Go
don't.
ahead, yes.
Okay, so the medical necessity is determined by Texas Medicaid Health Partnership. They're a third-party contracted entity, and it's actually, there's a state TAC rule, the Texas Administrative Code, that they go by based on that. And Karen, you may want to expand on that, but that's like the very basic one.
Yeah, no, I think that's a good explanation. Health plans don't make that determination. It is made by, you know, it's based on medical necessity, and it's based on, you know, your medical condition. Can we go back to, I want to go back to the other question about the, can a parent be an attendant? And I just want to say, I think there is one exception, and that has to do with consumer-directed services, that a legally authorized rep cannot be the employer of record leave. Yeah.
Thank you for that distinction.
Yeah.
Okay.
Yes, thank you, Karen, for the clarification on that.
We have a question. How come some nursing homes do not refer their individuals coming back to the community to manage care? So, you know, managed care would be involved only if that resident has been approved for Medicaid benefits. So if the facility is not referring the resident to the managed care organization and the person is enrolled in Medicaid, I would say that the facility is likely dropping the ball. But if the resident does not have Medicaid, has Medicare only, third-party insurance, private pay, then managed care wouldn't necessarily be involved. And again, the Aging and Disability Resource Center will do its best to provide options counseling to those residents who do not have Medicaid. And then one last question. It's my understanding that individuals can bypass the interest list for managed care if referred by the social worker at the nursing facility. So I'm not sure if that refers to bypassing the interest list for STAR Plus waiver. If the individual has Medicaid, she wouldn't have to go on the waiting list for STAR Plus waiver. But I'm not aware of an interest list for managed care. Are you all? Michelle, Karen, Kathy?
I'm not.
So, no, not that we're aware of. They may be discussing more the money follows the person. So if the member does not meet the criteria in the community, and if they leave to the community, they're put on that list. But if they're in the nursing home, they can request for us to start an assessment for money follows the person. Doesn't mean they bypass any list. That there's not none that we're aware of. It's just a different route that they go to get those benefits. But again, they would follow that process.
And I've gotten a comment, guardian or spouse cannot be paid either. So again, I think Kathy's advice is important. Not everyone will qualify as a paid provider. There are some people who, you know, they're eligible based on their familial relationship, but they may have criminal history, and that will rule them out as a paid provider as well. All righty, I think that is that covers most of the questions that we've received via chat. So it is my privilege to introduce to you Lisa Orosco, She is an attorney with approximately 30 years of human resources experience in both the public and private sectors. She currently serves as the Human Resources Compliance Administrator for the North Central Texas Council of Governments. In that capacity, she provides guidance to the agency regarding risk management and regulatory compliance with the operation and development of employment programs. As a licensed attorney practicing employment law, she has advised both businesses and employees in employment-related matters involving employee rights and compliance with legal and regulatory requirements. Lisa was a lieutenant colonel in the Air Force, serving as an administrative law judge for the Disability Evaluation System, and selected as a global subject matter expert for creating, leading, and managing personnel programs and initiatives for more than 400,000 military members worldwide. So Lisa, thank you for agreeing to participate and talk to us about Caregiver Leave.
Yes, absolutely, Donnie. I'm happy to be here. Can you hear me okay?
We certainly can.
Okay, great. So today I'm going to talk about leave that could be provided and actually mandated by law for caregivers through who they work for, through their job, through eligible employers, if they themselves are eligible. And the good news is that there are a lot of federally mandated rights that allow caregivers to take off from work to care for family members without losing their jobs. The maybe less good news is that it's sometimes confusing to understand what's available, who's eligible, and the process for using the benefits. So we'll try to break that down a little bit today and hit some of the high points that may leave you with some options. We'll talk about two types of leave programs that provide leave benefits currently, so an employee can care for a loved one. The first one is FMLA. This has been around for a while. A lot of people may be familiar with this. It's abbreviated FMLA for the Family and Medical Leave Act. It's been in place since around 1993, and this will allow employees to take time off of work to care for a spouse, a child, or a parent. This type of leave is unpaid, but it does allow for up to 12 weeks of leave for an employee to take off. We'll talk about that in detail a little bit more. And then currently there is COVID-related leave. And one of those is an FMLA type leave. We'll talk about it. But these are temporary programs in place now that have been put in effect since April 1st, and they have a time limit on them. And it does allow time off for employees to care for loved ones, and these are paid programs. So as we go into this a little bit more, one is called emergency FMLA, and one is called emergency paid sick leave. So under the regular FMLA, the Family and Medical Leave Act, of all the federal employment laws, this is one of the most popular and one of the most beneficial to employees. It is a very employee-favorable law. As I said, it's been in effect for more than 25 years. It's ongoing. There's no expiration date. This is available all the time if you're eligible. So I'll refer to this as regular FMLA. Employers who have this program and who are required to provide this program to employees are private sector employees with 50 or more employees, and most public agencies regardless of the number of employees. Public or private elementary or secondary schools are also required to offer this benefit regardless of the number of employees. And employees who are eligible to receive this type of leave are those who have worked for that employer for at least 12 months, and in the 12 months prior to taking the leave have worked at least 1,250 hours for the employer. And just a note, that 12-month period can either be in a calendar year or it can be in a look-back period from the time the employee takes the leave, looking 12 months back. It's an employer's choice of how they calculate that leave. And there are several reasons that you can use FMLA. I'll just list a few of them, but we're going to focus on that caregiver leave. An employee can use this when when they have a child, during the birth of a child, or when they adopt a child. They can use it for their own serious health condition. And then there are reasons they can use it if they're a caregiver for a military member, or if that military member and their family is deployed to a foreign country. But the one we'll focus on today is that employees can use this to care for a spouse, a child, or a parent with a serious health condition. And as with anything, there are special definitions to each of these words under the law. So I'll just hit on those real quickly. What would qualify as a parent and what would qualify as a serious health condition? A parent can be a biological parent, adoptive, a step parent, a foster parent, or even somebody who has served as what they call in loco parentis. And an example of that is someone who took on the role of a parent when the employee was a child. So this could be a grandparent, it could be a sibling, it could be an aunt, it could be anybody. Does not include a parent in law, but it could be beyond the traditional definition of a parent. And for a serious health condition, there are some qualifying factors, but I will point out that COVID-19 could be considered a serious health condition under this provision if there are COVID-related reasons for taking it. But generally speaking, a serious health condition is something that requires an overnight admission to a hospital, or it could be continuing treatment by a healthcare provider if that condition lasts for 3 or more consecutive days and there's follow-up treatment required. Follow-up treatment can be anything as simple as a prescription, or it could be additional doctor visits. But it could also be, this may qualify more in the caregiver realm, it could be to care for a parent with chronic conditions. And definition of a chronic condition would be a pretty low standard, one where they require periodic health visits at least twice a year. So again, this could be used to care for a parent with any of those conditions.
And Lisa, Marty apologizes for some reason. He's not able to advance the slides, so he hasn't fallen asleep.
Oh,
he's trying. We thought we were going to make it through the program without a glitch.
No, I apologize. I'm able to, it's just there seems to be some delay this afternoon, which that we didn't have this morning. So if it comes up a little slow, I'm sorry.
Okay, no worries. Well, should I just go on to the next slide and talk?
Yes.
There we go. Yes, we're right together. So the benefits that you can get under regular FMLA, an employee can get, as I said, are the 12 weeks in a 12-month period for the reasons that we talked about on the previous slide. This can be continuous leave or it could be intermittent. So for example, if you're sharing the duties with somebody else and you only need to take off work Monday, Wednesday, Friday to care for this parent, or you maybe need to take a doctor's appointment once a week or a physical therapy appointment a few times a week, you could use it intermittently as well. The benefits, even though, as I said, it is unpaid, the benefits are that it's job protected and that an employer can't interfere with your right to take it, and also can't fire you or retaliate against you for taking this type of leave, saying, no, that you're taking too much time off from work, we're going to have to let you go. This is job protected, so it will protect that employee who needs to take it. And also they must reinstate you back to the position that you had when you left. Say you took 12 weeks off and they hired a temp, they have to reinstate you back to that position or a similar position of equal level and equal pay. So there are instances also where you could use paid leave concurrently while you're taking that 12 weeks of unpaid leave. And in fact, an employer can require you to take paid sick leave or vacation leave that you have through them before going into an unpaid status. And there are a few requirements and a few limitations. Sometimes, probably rarely, a husband and wife may work for the same company. And in that instance, that would be 12 weeks that they could take together. They would not each be allowed the 12 weeks to care for a parent. As I said, the employer may require you to use your own leave during that time, short-term disability, other things that may qualify. And certification is required from a healthcare provider. So a doctor is going to need to certify that that person has a qualifying serious health condition. There are some forms to fill out, but they're relatively simple. And also you would need to let your employer know in advance when you need it. If you have advance notice, 30 days, if it's not foreseeable, then of course, just as soon as it's practical. So as an extension and amendment to FMLA, we have the emergency FMLA program that was just implemented April 1st that will expire December 31st, and this is related to COVID. I'm not going to hit on this too much because this may not be relevant to the audience, but I just mention it in case you hear of emergency FMLA and you think, oh, maybe there's a way I could get paid as a caregiver. This is paid leave and it is up to 12 weeks. It works just like FMLA, but there are some eligibilities that are loosened. You don't have to work for the employer for a whole year. You can work for them just 30 days to be eligible. It's going to apply to businesses, private employers with fewer than 500, and most public agencies, regardless of the number of employees. And it is paid leave up to 12 weeks, but it can only be used for one reason. And that's because you can't work or telework because you're caring for a child whose school is closed or their caregiver is unavailable due to COVID. So again, this may not apply to many participants when we're talking about caregivers for the elderly, but or nursing home residents, but I just wanted to throw this out there. Emergency paid sick leave could apply to taking care of a nursing home resident who has come to stay in your home. This again falls under the same realm of being a temporary law as it's related to COVID, April 1st through December 31st. The same eligibility in terms of private employers with fewer than 500 employees, public agencies. Some employers can, with fewer than 50 employees, can apply for exceptions, but they would have to qualify. All employees are eligible for this leave from the first day of hire. Full-time, part-time, intern, no matter the classification, it applies to all employees. And what it would provide for full-time employees is up to 80 hours of paid sick leave for the reasons that we'll go over on the next slide. And part-time employees would receive the number of hours that they typically work in a 2-week period. Some employers can exempt healthcare providers and first responders from this type of leave. So I do want to put that out there. You can't be required to take any paid leave before taking this leave. So this is a law, federal law that's been implemented, and an employer cannot say you have to take your accrued sick, vacation, paid time off prior to taking this if you qualify. So now we'll talk about some of those qualifying reasons. And again, there are several reasons. We'll focus on the one that applies to caregivers, but I do want to just mention the others in case those are qualifying factors for some of our participants as well. Again, the first qualifying factor is that you cannot work or telework. So if you're able to telework from home and there's nothing, even if it's because of COVID, but you're able to do that work, then you wouldn't qualify. But if you're unable to work or telework because of any of these reasons, you could qualify. One is that you're personally under a federal, state, or local government quarantine or isolation order related to COVID. Another is that you've been advised by a healthcare provider to self-quarantine. Or it could be that you're experiencing COVID symptoms and you're seeking a medical diagnosis. The one that is going to apply to today's topic is if you're an employee who's caring for an individual under a quarantine or isolation order. And I'll go into more detail about exactly what that means. It could also apply if you're caring for a child whose school is closed or a caregiver is unavailable. And in a sixth category, any other substantially similar condition defined by the Secretary of Health and Human Services, which hasn't come out yet. We're going to stick on this slide for a minute so I can go into a little more detail. about how this applies to caregivers. But first of all, let me point out that some of this paid sick leave is at 100% of your pay, and some of it is at 2/3. Anything having to do with the care or quarantine or isolation of yourself is going to be at 100% of your regular pay or of minimum wage, whichever is higher. If the care has to do with caring for somebody else, the reason for the leave has to do with caring for somebody else, that's going to be at 2/3 of your pay. And so what they mean by a quarantine or isolation order, we've gotten a little more guidance about this from the Department of Labor. Initially, we did not think that this applied to shelter-in-place orders that are currently being imposed by the state and local authorities, but we have gotten further guidance that those do apply. So if an isolation order, a quarantine order has caused you not to be able to work or telework, even though there's work available for you to do, then you could qualify under this order. In terms of being a caregiver, when you can care for someone else who's subject to an order like this, is if they're unable to care for themselves and they depend on you for care, and if providing them care prevents you from working or teleworking. So this is an immediate family member or someone who regularly resides in your home, but it's also somebody who, if the relationship creates an expectation that you would care for them in a quarantine or self-quarantine situation. So then you could qualify as the caregiver, and that individual depends on you for the care. Okay, we can wrap this up with the next slide, which is just a comparison. I apologize, this is really tiny. I didn't realize it was going to be so small. This is just 3 columns outlining each one of those programs and the differences between. I'll summarize the high points really quickly. As a caregiver, you can qualify through your employer for different types of paid or unpaid leave. In the far left column, we have the regular FMLA. That's an ongoing program, provides 12 weeks of unpaid leave. Your employer can require you to use sick or vacation leave for that, and that can be used to care for a parent with a serious health condition, which may include condition related to COVID-19. There are other reasons that you can use it as well. The middle column, the emergency FMLA, can use that for one reason only, and that's to care for a child whose school is closed or caregivers unavailable because of COVID-19, and you can't work because of that, or telework. And then the third far right column, which may be the most applicable to today's participants, is the emergency paid sick leave. Again, temporary basis only, April 1st through December 31st. For reasons related to COVID-19 that you are unable to work. The eligibility is immediately. It applies to employers with fewer than 500 employees or public agencies. You can, as a full-time employee, be entitled to up to 80 hours of paid leave if you have a qualifying reason. And this can be used not only to care for someone with symptoms of COVID-19, but even if they're under a quarantine or isolation order, they've been advised by a healthcare provider to isolate under these conditions, and maybe because they are more prone to getting it. Could be one of the reasons that a healthcare provider would tell them to isolate. And this is going to be 2/3 of your pay, up to 80 hours. And that wraps up the presentation. I know I went through that really quickly, but hopefully that gives people some guidance and guidelines that maybe they may qualify for, that may help out.
Fantastic, very helpful. Thank you, Lisa.
Certainly.
We have one question. Can we get a copy of this presentation? Absolutely. You should have gotten a copy of the presentation from Marty Mascari. If for any reason you didn't get it, send an email either to Marty or me. I'm Donnie, and we will be happy to get you Lisa's presentation.
All of the there's 2 links that should have gone out in an email at about 8:30 this morning for everyone, and that was with the description of the CEUs plus the download links for both of the presentations this morning's and this afternoon's. If you didn't get that, please you can use the Q&A email I've got on the screen right now, or you can email me to my regular email address, and I've had about 10 people ask for that. I don't know what the glitch has been, but I apologize for that.
Yeah, we will definitely get that to you. So let me give our participants just another minute or two to see if they have any questions that they'd like to submit. And again, I want to express my gratitude to all of our presenters. As I mentioned this morning, we had less than a week to plan and conduct this presentation, which I think is the quickest program that I've ever been involved with. And I am just so indebted to all of our speakers who were so gracious with their time. So I am not seeing any other questions. So Marty, do you have anything that you would like to say in closing?
I do not, just to make sure that the people that are wanting CEUs go ahead and send us a certification email once this is anytime now, that you listen to both of them in full, and that you've and once you complete the Survey Monkey, that you've completed that, and then we'll get your certificates back to y'all. And ultimately, we are recording these. I haven't found a platform to host them because of the size yet, but we're looking to host them someplace so we can have those links for you, so you can go back and watch and listen to the webinars.
Fantastic.
Hey, Donnie, this is Karen. I mean, I can't let you go without telling you what an excellent presentation this has been for you and Marty. I mean, you and Marty just really worked really hard to put this together, and I think, you know, gratitude and recognition needs to go to you all for the work that you all did as well. So thank you so much for everything.
Oh, thank you for those kind words. We just appreciate y'all so much. All righty, so it is 3:30, and we will conclude this this webinar on time. Again, thank you for being with us both this morning and this afternoon. Bye-bye.
Bye. Thank you, Ms. Donnie.